My name is Pavlos Msaouel. I'm from the University of Texas MD Anderson Cancer Center, and I would like to talk a bit about the clinical trial that I presented, the phase 1/2 trial of the combination of the novel tyrosine kinase inhibitor Sitravatinib with the immune checkpoint inhibitor nivolumab. We tested this regimen in patients with advanced or metastatic clear cell renal cell carcinoma that had disease progression before on anti-angiogenic therapies like anti-VEGF therapies like pazopanib, sunitinib, or axitinib. The trial used one of the newer Bayesian designs, so it's not what you usually expect where you have a phase 1 and then an expansion arm that's more of a phase 2 and efficacy arm. This is the kind of trial where for the same patient, you evaluate both toxicity and efficacy. So you gather that data from each patient individually, and the algorithm, it's called FTOX, helps decide the next doses for each subsequent cohort of patients. So that was one of the novel things about that trial. We tested various doses of Sitravatinib, 80 milligrams, 120 milligrams, and 150 milligrams. The FTOX algorithm determined that 120 milligrams gives a very good balance of toxicity and efficacy. Efficacy-wise, we noted that whereas with historical data of single-agent nivolumab, that's what was seen in the CheckMate 025 trial, you would get an objective response rate of about 25%. With the addition of Sitravatinib, we found an objective response rate of 39%. More importantly, the responses were durable, even when you had disease control, not necessarily a full partial response or complete response. The control was durable, and it is for this reason that whereas nivolumab on its own historically has a median progression-free survival of about 4 to 4.7 months, our trial showed a median progression-free survival of 10.3 months. So that's more than doubling the progression-free survival. The other important aspect that I would like to highlight is the toxicity profile, and I think that this is important because this is a new TKI, and it does tend to behave differently than other TKIs. And so one thing to highlight is that the most common adverse event was diarrhea. Interestingly enough, this was diarrhea because of the Sitravatinib, not because of the immunotherapy. It was not immune-mediated diarrhea. The other thing to highlight is that you would see less hypertension and less hand-foot syndrome with Sitravatinib than you would see with other similar tyrosine kinase inhibitors. On the other hand, Sitravatinib would be more likely to cause, most of the times clinically asymptomatic, elevation of lipase and amylase. So we had one grade 5 event, one patient death, nivolumab-related myasthenia gravis, and we had some grade 4 adverse events in the 40 patients that we evaluated. In 3 patients, we had increased lipase that was clinically asymptomatic, that was grade 4. In 2 patients, we had increased amylase, grade 4 asymptomatic, and in 1 patient each, we had grade 4 AKI, acute kidney injury, hypertension, and sepsis. So those are the things that I think are highlights of our trial. And based on the results of our trial, this combination of nivolumab and Sitravatinib with a dose of Sitravatinib 120 milligrams is now actively being tested in phase 2 and phase 3 trials in multiple malignancies, including urothelial carcinoma, head and neck cancer, and non-small cell lung cancer. And of course, we intend to expand our trials and our portfolio by doing studies with various Sitravatinib combinations in clear cell renal cell carcinoma as well.